Good evening, everyone. My name is Joe Senegato. I'm the Regional Marketing Manager for Spalding Rehab Network's Southern Region, including Cape Cod. And thank you for joining us for the first of 3 virtual sessions that we're hosting in support of our engagement with the Falmouth Road Race 2020 at-home edition. A couple of housekeeping details. First, please note that your microphones have been automatically muted for the presentation portion of tonight's event. You can still ask questions during the presentation by using the chat box feature. If you're not familiar with that, if you just roll your mouse over the screen, you'll see a little box pop up on the bottom that says chat. So if you have any questions as we're listening to a presenter this evening, please feel free to document them there, and I will be happy to follow up after the presentation. We also have planned time to answer your questions, so we'll do that as soon as the presentation is over. And if time permits, we'll also open the microphones and allow you to connect directly with the presenter. Our presenter for this evening is Patrick Davin, PT, DPT, CSCS, who is joining us from the Spalding Rehabilitation Network Outpatient Clinic located in Sandwich, Massachusetts. He'll be discussing with you tonight the technology available to help runners through our frame-by-frame video analysis program. Today's session will be recorded, and without further ado, may I present Patrick Davin.
Hi, everyone. I'm just going to share my screen here. All right. Thank you, Joe. Thank you for that introduction and helping to set this up. Definitely appreciate that. And thank you all for being a part of this tonight. So as Joe said, my name's Pat Davin. I work over at the Sandwich Clinic as a physical therapist. I see mostly orthopedic issues, treat a lot of runners, some of them injured runners coming, through us via the PT route, others through the healthy running program that we have over there. I'm also a runner, or try to be myself, so can relate to the whole injury aspect and wanting to continue to run healthfully. So I wear that hat as well. So let's get going. So actually, hang on, I am just gonna move this down. So little background, running injuries are, very prevalent. Up to 80%, 79.3% sustain lower extremity injuries at some point during their training or competition. So if we look at this in comparison to other sports, and we look at the breakdown of injuries per 1,000 hours, running's in the range of 17. As when you look at cross-country skiing, you got 1.7 for males, 2.3 for females. Swimming, which we, look at as sustaining a lot of overuse injuries as well. Close to 2 in females. Close to 2 in males, females 3.25. Soccer, you're looking at more of a contact type sport. Even that is well below the 17 injuries per 1,000 hours. Even triathlons, which, are a combination of cardio and endurance events, is much, much lower than what we see in running, okay? So although some of these other sports may have a greater severity of injury, the frequency of running injuries is unsurpassed. So the location of these injuries, up to 50% are occurring at the knee, okay? Lower leg, these are more your shin splint, tibial, posterior tib tendinopathies. You're looking at anywhere from 9 to 32%, depending on the study. Foot, where you're looking at your plantar fasciitis, anywhere from 5.7 to 39%. Upper leg, where you're looking at your quad and hamstring strains, anywhere from 3.4 to 38%. Ankle, up to 16%. Going up to the hip, pelvis, and groin, up to 11.5%, and even to the low back, up to 19%. Quite a range on these numbers, I know, but it just depends on, this is something that's been studied quite a bit, so it just depends on the particular study that you're looking at, okay? And 80% of these are overuse injuries. What are we looking at for types of injuries? Most common, patellofemoral syndrome. Layman's terms, you kind of hear this called runner's knee. Iliotibial band friction syndrome, tibial stress syndrome, aka shin splints, plantar fasciitis, some hamstring issues, patella tendonitis, tendinosis, just a chronic form of that. Achilles tendonitis or tendinosis, again, just a chronic form of an Achilles tendinopathy, meniscal injuries, as well as some stress fractures. What are some of the risk factors that we see? This is, again, has been researched quite extensively, and age, of course, makes sense, plays a factor. Interestingly, there's a kind of medium age there that we see it the most in, people between 45 and 65. Males getting injured more frequently than females. Prior injury is a big one. You know, your risk of sustaining, you know, having knee pain again if you've had runner's knee in the past is much higher. BMI, that's body mass index, over 30 is a risk factor. This is an interesting one, the use of orthotics in inserts. Okay, we'll talk a little bit more about this, but this is something that, you know, in PT, we oftentimes traditionally have used it as a way to treat the injuries. And so this has actually been studied, and it's actually been found to be a risk factor for developing further injury, okay? I have changed my practice a bit over the years in terms of, this used to be one of the first go-to things I did. Now I'm a little bit more selective on who I use these in, you know, because it has been found to be a risk factor for injury. Training errors, this is a category that involves a complex interaction of intensity, volume, frequency of running. Okay, there's a complex interaction of those factors, you know, including surfaces that we're training on, footwear. So there's a whole bunch that falls into that category, and gait mechanics, which is going to be what we focus on tonight. All right, those last four, the starred risk factors there, are modifiable. So what do we do about them, right? BMI, sometimes easier said than done, but we know, you know, we should be keeping best we can an ideal weight for our height. BMI has been found to be kind of, we still use it, but if you're, you know, those, I've seen people who are very muscular have a BMI over 30, they're obviously in great shape. So it's not something that's a be all end all type of measurement, okay? Orthotics and inserts, I think we got to take a look at maybe being a little more selective. All right, I told you I've changed in my practice in terms of how much I prescribe these and use these. Doesn't mean I don't use them at all, but I'm just a little more selective on who I use these with. Okay, training errors. So we have to look at how quickly we're progressing our volume, how much we're adding on when we're training for a particular race, how quickly we're adding on, making sure we're not trying to increase distance and speed at the same time. Okay, there should be separate runs set aside for that. Okay, and then of course the focus of tonight's presentation will be on gait mechanics. Why should we do gait analysis? It's more sensitive than the naked eye. Okay, I've been doing this now for, I've been a PT for about 13 years. Probably you've been using the camera for the last 9, and I feel like I should call those patients of the first 4 years that I was doing running analysis and just tell them to completely forget anything I told them, because once I started using the camera, you realize how much, you know, more accurate you're seeing what's going on in a person's running gait, and how much more sensitive the camera is than just using the naked eye. Okay, you could do a frame by frame analysis of the running gait. We have a 120 frames per second camera, so that catches a lot of what's going on, you know, in the patient or client's running gait. We use a Canovia program that we upload the video to, and that has the capacity to be able to take joint angle measurements through this program. It provides visual feedback for the runner. Okay, so you know, a lot of times we do before and after comparisons, and you know, that visual feedback is very, very helpful in terms of how we're doing, you know, both as the therapist and for the runner themselves, in terms of seeing the differences, the changes that are being made or not being made. This is sort of a boring slide here, but basically what this is telling us is that there's these complex labs. We are fortunate to have one in Cambridge as part of Spalding. It's part of the National Running Center, run by Irene Davis, who has done a lot of the research in gait mechanics and straight pattern of the foot. And it's amazing what they can do up there. They use a bunch of different cameras all on at the same time to get different angles and perspectives. They have force plates, so it's amazing what they can do. Basically, what the research is saying, that for the two-dimensional cameras that we use, they are reliable, they're reproducible between clinicians, and the angles that we're seeing using the two-dimensional systems are accurate enough. You're not going to get exactly the same information, but you can definitely transpose what you find in these two-dimensional systems to the larger, more expensive labs that are out there. So what are we looking at? We're looking at all segments. We look at basically the whole body, the trunk, arm swing, pelvis, hip, knee, and foot. We can throw head position in there as well. We look at both phases, the swing phase and the stance phase of both sides. We're going to get all views. Usually I start posterior, go lateral, and look anterior, finish up on the other side, okay? So what are the types of things we're looking for? Vertical oscillation, basically that's the bounce in your run. Arm swing, base of support and crossover. Pelvic drop, hip adduction, knee position, whether you're valgus or varus, also known as knock-kneed or bow-legged. Rear foot position, trunk lean, stride length, cadence, and foot strike. Okay, I know I went through that list pretty quickly, but we'll be going through each one of these tonight. And as Joe mentioned, if there's any questions that you guys come across when we're going through this, you have the option of putting them in the chat, so you don't forget to ask later. So vertical oscillation. This is, as I mentioned a second ago, basically the bounce that we get in the step. How much, obviously if you want to be the most efficient runner, you're trying to put as much force and effort into getting from point A to point B and not necessarily the up and down, okay? So larger oscillation, so more of that up and down motion was related to greater energy expenditure and worse performance in runners in one study. And larger oscillation, lower vertical oscillation, is found to have reduced loading rates and vertical ground reaction forces. So basically, in the simplest terms, you are hitting the ground less hard with a reduced vertical oscillation, okay? So let's look at this a different way here too, in terms of efficiency, okay? So if we have a vertical oscillation, if we're looking at the difference between elite runners and kind of your everyday runners, like myself, and there's a 3-inch difference in their vertical oscillation with each step, okay? And we look at taking about 1,000 steps on average per mile, okay? Now let's do the marathon thing. We'll multiply that times 26.2 miles. That is 78,600 inches, or 6,550 feet of vertical elevation during a marathon. Who wants to do this when they're running a marathon, right? So we want to cover that 26.2 miles as quickly as we can, from getting from point A to point B. If we're looking at how much just a 3-inch difference in vertical oscillation can make, you're basically climbing a mountain, climbing Mount Washington over the course of a marathon. So let's move on to arm swing. We're looking at an excessive arm swing or lack of. We're looking to see if it's symmetric from side to side. We look at the patient or client shoulder height. We're trying to determine also where the deficiency is coming from. Okay, so if we look at the client in these pictures here, her left arm swing is much more. So if you guys can see where I'm pointing here, her left arm swing is much more prevalent than her right. Okay, her left arm almost, at least half of it disappears. Her right one is still pretty visible in that shot, right? So this can be any number of things. So here's where we got to take what we see in the video and test some things out in the clinic to see where this is coming from, right? Is it a lack of hip extension strength on her left side? So she's trying to push that hip through by swinging her arm a little more forcefully, right? Does she have a lack of lumbar rotation here to the left? Okay, so is it more coming from the trunk, right? Is it pectoral muscles that are pulling the left shoulder forward, or weakness of the scapular stabilizer. So sometimes we got to see what we, see what we find in the video. We're going to correlate that to what we find clinically. Okay. Crossover and base of support. This is another. This is actually a really common thing that we see in terms, especially in female runners, in terms of how much they cross over. Okay. So if we were to draw a line straight down her back, it should land on the medial malleolus or on the inside of your ankle, that bony protrusion that sticks out of the inside of your ankle. Okay. I've seen worse, but she definitely has some pretty good crossover going on here. Okay. So it's correlated with hip and knee issues, particularly in females. And in this picture, we're seeing excessive crossover and narrow base of support. Okay. So we would like that line to fall right through her back and in on her medial malleolus. Pelvic drop, another super common thing that we see, should be about 4 to 6 degrees. So, barely noticeable, with definitely the naked eye, and even with the camera, you shouldn't notice too much of a drop there. Weakness is going to be in the opposite side. Okay. So our patient here is in right stance and dropping on the left side, the weakness over on her right glute. Okay. This is correlated with IT band, SI joint, low back, hip and knee issues. Another very common thing that we're working on, that we see in the clinic and that we work on during our gait retraining. Excessive hip adduction and genu-valgum. Okay, so this here is more of that knock-knee position that you're going to see. Okay, so this is the hip adduction is the upper part here. It's basically how much the leg is coming in. All right. And a lot of times you see these things hand in hand. So a lot of times you'll see the excessive hip abduction with the genu-valgum or knock knee, with the crossover and with the decreased base of support. Okay. A lot of times that's all happening together, and it sounds pretty terrible, and there's a lot of things to correct there, but sometimes just getting the glutes more active can be an easy way to fix all of those issues. Okay, so again, more common in females, typical cause of patellofemoral syndrome or runner's knee. Weakness of the glutes oftentimes is a major factor. Excessive pronation. This picture here, I cringe when I look at, but that's how much the foot is falling in. Okay, so the arch on the inner part of your foot is falling inward. Okay, so this is associated with a whole bunch: plantar fasciitis, Achilles tendinopathies, calf strains. If you look at even the picture of how hard this guy's calf is working, right? So the calf has a supinatory influence. So someone who's overly pronating, they're really overusing their calf muscles as well as their tibialis posterior. Oftentimes this is associated with medial tibial stress syndrome or shin splints, and that's oftentimes because of the overuse of the tibialis posterior tendon, which is one of the primary muscles in trying to control that excessive pronation. It's also associated with the patellofemoral syndrome or lateral knee pain because of the compression you're getting on the outside of your knee. So excessive supination, a little less common. We definitely see the excessive pronation quite a bit. This is going to be the picture on the right. Okay, so comparing these three pictures, we got a neutral position of the foot. This is looking at the back of someone's right foot. Here's the pronated position, much more common in the clinic. We have to correct that through sometimes orthotics, a lot of strengthening of the glute muscles as well as foot intrinsics. Supinated position of the foot. This is less common, but when we see it, it's usually more mobilizations. This is a rigid cavus position of the foot, and a lot of times you have to really work on stretching that out and actually getting it to pronate more. Okay, overpronation is not a good thing, but we do need some pronation to help absorb the impact. Okay, so these people here, the over supinators, are not absorbing that impact through pronation. So some of the things that can come up the kinetic chain are peroneal tendinopathies, lateral ankle sprains, medial knee pain, plantar fasciitis, stress fractures of the foot. I'd say you can go up even higher, and these are the people that tend to have more back pain and SI joint issues because that force is not being absorbed by the pronated foot. Okay. So trunk lean, this is a comparison. The picture on the left is someone running a little more erect and upright than we like to see, versus someone who's running with a 5 to 10 degree forward flexion of their trunk. Got to figure out the why. Is it due to just postural alignment? Do they stand like that? And you know, therefore we have to work on some postural type issues they may have, take pectoral musculature, or extension, hip flexor tightness, weakness of the glutes. Okay, all possible things that could be affecting someone who's either too far forward or too far into extension. Okay, trunk lean is something we play with people with knee issues and patellofemoral syndrome, or runner's knee. A little bit more of a forward flexion has been found to reduce some of the strain and stress on the knee. So that's something that we also tend to play with a bit in terms of reducing the strain on the knee. Now, someone with back pain who has more of a disc issue, we may promote more of this upright running form. You know, they if someone's younger and has a disc issue, they tend to not want to be in a forward flex position. So a more upright form may be, it might be a little less efficient for them as a runner, but it might help them to run a little more pain-free. So it just depends. We really have to do this with everybody in terms of trying to see what their particular issues are and individualize what our recommendations are to them. So stride length, okay, this is I would say most of the patients, probably, you know, 80 to 90% of the patients you see are probably overstriding, based on what the current research is showing. Why does this really matter, right? Well, decreased stride length has been found to actually have a lower energy cost, which is interesting because the next slide is going to talk about cadence. You're actually taking more steps when you have a decreased stride length. However, overall, the energy cost is still lower. Okay, decreased center of mass vertical excursion. Okay, so that's the vertical oscillation, the bounce in your step that when you're running. Okay, decreased ground reaction force, decreased impact peak. We'll talk about that in a slide, but basically that's how hard you're hitting the ground. Okay, decreased shock attenuation, decreased energy absorbed at the hip, knee, and ankle joints. What's that mean? Hopefully less injuries to those joints, right? Decreased ground reaction forces. So, I mentioned that twice, but this basically you're looking at decrease the amount of force that is being transmitted up the leg when you decrease the stride length and increase the cadence. Okay, so there's a lot of watches and accelerometers that will tell you what your cadence is without having to figure it out, but I still put this in here, basically how to get your cadence. So you count your steps taken by both feet in 15 seconds or 30 seconds for 1 foot, and you multiply it by 4. Okay, I say estimated ideal here. You see these numbers thrown out there a lot, the 170 to 180 range. It really depends on a whole bunch in terms of body type and stride length, but we do want to quicken that cadence for most people into, you know, the 170 to 180 range. Okay, but individually we're going to look at increasing it by about 5 to 10% of the time. Okay, so if someone comes in, has a cadence of about 160, we are going to try to increase that by 8 to start, to get them around the 168 range and eventually more into the 176 range. Okay, this is inversely related with stride length and impact peaks. Okay, so at increased cadence, you're going to reduce your stride length. You're also going to reduce your impact peaks. Very important in preventing injuries. Okay, use of metronomes can be helpful in retraining of this. Subtle increases in step rate can substantially reduce the loading to the hip and knee joints. You're decreasing those ground reaction forces. Okay, something we definitely do to help prevent injury as of the most common running injuries that we see. Okay, reduce load rates and braking impulse as well are noted with the increased cadence. All right, so foot strike. On the left, you're going to see heel strike, and on the right is your forefoot striker. Okay, it's kind of hidden there by the bar, but up to 94% of the runners rear foot strike. Okay, so in shoes, in shods, that's what we're going to see. 94% of the runners, just the way sneakers and shoes are made nowadays, that is going to be what we see. Okay. So let's play this video here. Oops. All right, so you're going to see her running with a heel strike to start, and we did some gait retraining on her. Now, it does definitely not happen this fast. Okay, we're looking at 6 to 8 visits at least to make a change like you just saw in the video. But I wanted her to do both so people could get the sense of where she started and then what we were able to retrain her to do. So let's just play that again. Definitely heel striking here. Okay, again, 94% of the patients and clients, that's what we see. She transitioned over to a nice 4-foot strike after 6 to 8 visits. Okay, and again, this is dependent on the individual. All right, so the 4-foot strike has been shown to reduce the impact peaks. And let's look at this slide here. So here, this is basically a visual of what happens at the impact peak in a rear foot strike. Okay, so this impact peak is basically how hard we are hitting the ground. Okay, so when our heel hits the ground, which again 94% of the patients and clients are going to be heel strikers, this is what we're going to see, this impact peak. This is the tibial shock. Okay, so the tibial shock and the impact peak happen at the same time. Okay, and that's the force that your leg is hitting the ground with. Okay, so again, this is correlated with your impact-related injuries. Okay, so things like stress fractures, even your overpronation type injuries are going to be affected by the impact peak. Okay, because what happens is the rate of pronation that actually causes the injuries, not necessarily the amount. If we can reduce the impact peak, and most of the time we're doing that by decreasing someone's vertical oscillation, by shortening their stride, by possibly making them more of a 4-foot striker, then this is going to be disappeared. This impact peak, these peaks that you see here are going to flatten out, and it's going to be a nice level. So the force is going to be, it's not going to be that quick force, like hitting the bottom of your foot with a hammer. It's going to be more dissipated over time. Okay, this is a slide that Dr. Irene Davis over at the Spalding National Running Center let me use for this presentation. So in terms of force and the shock wave from this impact peak that's going up your leg, okay, if we look at the joints going up and even going up to your head, okay, this again is another slide from Dr. Davis. She is saying that those heel strikers are hitting with a force of 10 Gs, okay. Now this has to be absorbed up the joints basically up into your head. Okay, so eventually the head is gonna still have some impact, 1 to 2 Gs of force. Okay, but if you're starting with 10, that's a whole lot more for these joints in between to absorb. Okay, so the body's a huge filter attenuating the shock as it travels upward. Greatest shock, no surprise here, because if you think about that slide that we had earlier where the most injuries are, we're looking at it being at the knee, right? So greatest shock attenuation is at the knee. Also the most common site for injuries. Okay, so the more we can reduce it at the foot, the less shock the body is going to need to attenuate, right? How do we do that? That's where we do the things I mentioned. The vertical oscillation, we try to decrease the decreased stride length, increase cadence, and the 4-foot strike. Okay, so getting off a little bit on a tangent here, the 4-foot strike became popular. I don't know if you guys have read the book Born to Run and all the minimalist type shoes that came out about 5 to 7 years ago, maybe even a bit longer ago. So there is a training process that you need to go through to be able to learn to do this. I mean, we don't even try to change anybody's strike pattern until they're able to do 30 single leg heel raises in full range and 10 single leg squats with good form. Where people get themselves into trouble was just they read this book or read about 4-foot striking being a good thing, and they just went and tried it. And you can the worst thing to do is to fix one issue but to cause another issue in doing it, right? So what we started to see was stress fractures of the foot, Achilles tendinopathies, calf strains, because there was so much more force going through the calves at this point. So It's something that takes time, 6 to 8 visits, even once you have the strength that and the, the single leg squat form that we want you to have. Okay. So just something that we do, in preparation for training someone to be a 4-foot striker, if that's appropriate for what we want to accomplish with them. So what do we do when we do the gait analysis? What are we doing in the clinic? Okay, so is it a hardware versus software issue? Okay, the hardware issue, we're looking at muscles that are weak. Okay, oftentimes you see this in the gluteal musculature, the calves, quads, hamstrings. Next week, if you've signed up for the virtual presentation given by my co-worker Keelan, he will be talking more about the strengthening. So I'm not going to steal his thunder on that, but basically, these are some of the muscles that we really have to focus on, that I see in the clinic. Okay, stretching those that are tight, right? Hip flexors, hamstrings, calves. 2 weeks from today, there will be another one of my coworkers, Danielle Nardi, giving a presentation on yoga for runners. So that's going to help stretch some of these muscles that are tight. Okay, and as well as just teaching you the benefits of yoga for runners. Okay, so strengthen the muscles that are weak, stretching those that are tight, mobilizations, myofascial release, soft tissue work. This oftentimes is the stuff that you're seeing in PT, right? The stuff that we start with. If it's a software issue, so now you strengthen the muscles that are weak and you stretch those that are tight. Now you got to put it all together, right? Now you got to integrate the mind-body connection here, because strengthening by itself is not necessarily gonna lead to good mechanics with a squat or a lunge. Okay, so proprioception, kinesthetic sense, those are big fancy terms for basically where the joint is in space. Okay, so a big part of what we have to do in the clinic is retrain the software issue that's going on. So how to perform a single leg squat or lunge or step down with appropriate form. Someone may have the strength to do it, but the mind-body connection isn't quite there. So we have to train that appropriately. Okay, this is before we even get them on the treadmill a lot of times. Okay. So again, just a quick slide, not to steal Keelan's thunder for next week, but these are some of my favorites, okay, in terms of what we do for strengthening for runners, okay? Not to steal Danielle's talk, but here's some of the more common stretches that we'll do, and as well as the bottom 2 pictures there, some foam rolling, which I'm sure a lot of you guys have seen already. Some of the more common proprioceptive and kinesthetic sense type activities. Okay, this is a single leg deadlift or single leg squat here in the middle, a step down here on the right. But is this enough? Okay, we used to think it was, all right, and we used to think just doing the strengthening would lead to better form on the treadmill, right, and with our runners. That's all we had to do. So we thought, but a few studies have shown that that's not the case. Okay, this one by William Davis looked at 20 healthy females, did some hip strengthening, and worked on single leg squat mechanics for 18 visits, 3 times a week for 6 weeks. Okay, they got stronger. Their hip strength was significantly improved, and their mechanics on the single leg squat were definitely better, but did not change their running form one bit. Okay. So with gait retraining, okay, the results were different. This first study used a more high-tech system, more of the real-time motion analysis, multiple cameras going on, one of those higher, more technical clinics, okay, and so they found that there was reduced vertical load rates, hip alignment improved during running in terms of the adduction and internal rotation and the contralateral pelvic drop. Interestingly, it even improves the single leg squat. So they actually, in this study, they did not do any strengthening. Okay, they just focused on the gait retraining, and they made these improvements. Okay, the second study that's listed tried to do a more cheaper, cost-effective method of doing it without the high-tech labs, and they were able to basically repeat the study and get nearly identical results with just using a mirror for visual feedback. Okay. Now, I do think you need some combination. With all my patients and clients, I know these two particular studies just did the gait retraining. I definitely think you need to work on the strengthening, the proprioception, the kinesthetic sense, some flexibility type issues, and then the gait retraining. I think that's the best way to really get after it. So running gait retraining, what do we do with it? It's going to really focus on on the individual. Okay, we're going to look at prior injuries. Are they impact related? Should we be looking at reducing ground reaction forces and impact peaks? Can we correlate what we're seeing with improper, inefficient gait patterns? Right. So sometimes we'll see stuff on a video analysis that has nothing to do. It might be completely on the opposite side that they're coming for. Okay, so maybe it's something we still try to get them out of. That in terms of inefficient gait patterns to prevent future injuries, but really just depends on the person. You want to be able to correlate what you see on the gait analysis with their running history and the injuries that they sustained, right? Depends on their goals for running, and really, the goals for injury prevention. Runners, one way to definitely upset a runner is to not let them run, right? So in terms of injury prevention, that's important for us as the therapists as well as the patients. So how do we do it? Something called a phased feedback system. Okay, it happens in two phases: acquisition phase and transfer phase. Okay, basically it's how much feedback you're giving the patients. A lot of times when we're trying to do the gait retraining, we're looking at 6 to 8 visits. Sometimes it happens quicker, sometimes takes longer, but basically those first 2 to 4 visits, you're providing a whole bunch of feedback. Basically nearly 100% of the time. And then the transfer phase, there's a systemic removal of it, systematic removal of the feedback. So then it's becoming ingrained. It's a new motor pattern for them. Okay, it's ingrained in their muscle memory, basically. So what does the feedback look like? Okay, sometimes it's auditory. Some of the more common things that we use are verbal cueing to squeeze the glutes, basically tightening the butt muscles, to land softer. If we find that someone's really kind of landing hard on the treadmill, increase the steps taking over the next 15 seconds. If we're looking at trying to increase cadence, reduce bounce. If we're looking at trying to reduce someone's vertical oscillation, use of a metronome. Okay, we mentioned that at the beginning of the talk, but there's on JogTunes, iTunes, and Spotify. Basically, you can put in what you want your cadence to be, and find songs to run to based on that. So, kind of a cool way to use songs to help you get the cadence that you want. Okay. Visually, we use a mirror oftentimes, as well as the video analysis. We'll do the video analysis, and we'll keep repeating the video analysis to see if things are changing. Okay. Feedback. One of the more common things we're seeing now is the use of accelerometers. Okay, these little devices that you can put on your shoe or wrap around your distal tibia, basically at your ankle. These can track cadence, stride length, vertical oscillation, vertical ratio, and ground contact time. So that's another way to provide feedback to you as well. So, just a couple examples here. What are we trying to change, right? So that's that pelvic drop person on the top left there. Some gait retraining, and that's that same person now who's much more level. Okay, that's definitely more in that 4 to 6 degree range. Okay, and we see our heel strike down below. We were able to transition her to a 4-foot strike. This is actually the same runner, so she had quite a few things going on, but we were able to make some changes with her. Okay, so why do video analysis? All right, helps you understand your running mechanics, how they may lead to potential injuries in the future, or explain why you've had injuries in the past. Teaches you how to become a more efficient runner. Gives you that visual feedback on any abnormalities or inefficiencies of your gait pattern. We get some runners that just come in, then they're not hurt, they're just new to running and unsure of what good running form is. Okay, so we get those types of clients as well. So here at Spalding, basically, a couple of different ways we can help you if you need it. If you have been running and not hurt and uninjured, I don't care if you're running on your hands, then keep going, but if you are hurt, a lot of times I see most of the runners through a physical therapy referral, just doing the standard PT. We have a healthy running program as well, for those runners that aren't hurt and but really don't think they're doing something right. So that we'll talk about a little bit more in the next slide, but that's another option for you, as well as our Dr. Irene Davis in Cambridge. In her amazing center up there. They do fantastic work up there. I've learned a ton from her myself. It's something that you can get a running analysis done there, and they can show you more stuff in regards to ground reaction forces and using the use of force plates. They have more of what we do is the two-dimensional running analysis, and they have the more extensive lab up there. So healthy running programs, postural assessment, functional movement analysis, video analysis of your running gait, flexibility and strength, individualized exercise instruction. Okay, there's the rates on that down there. That's me still trying to beat that 56 minutes for the Falmouth road race. This is my nemesis. It's a race I love to hate and hate to love, I think. But references here. And at this point, I'd like to open it up to
That's great. Well, thank you, Pat. We appreciate the information. It was very informative. As many times as I've learned about this, it's nice to learn about it again. I do have a couple of questions that came in with the registrations. I also have a question that came up during the presentation. Where on the body is vertical oscillation measured?
So in the clinic, we look at basically like the top of the head, how much it's going up and down, basically. Okay. So they have accelerometers that you can put on your ankle. You can attach it to your shoe, and that can also measure the up and down as well. So you can measure it at any point. It's just the easiest thing to do with the two-dimensional system that we use is looking from all views, from the posterior view, from the lateral view, and just looking at the bounce, basically how much bounce there is to the person's running gait.
Okay, great. Are there other questions from the audience?
And again, I apologize here for not.
That's okay. We can always drop them into the chat if folks are having a hard time unmuting. Does gait analysis, I'm going to read you some of the questions that are coming in now. Does gait analysis also give types of shoe recommendations? So when you're doing that gait analysis, are you able to do that? And there is a question that came in that's sort of similar with regard to shin splints and finding the right kinds of shoes and inserts. So I think we could maybe look at that together.
Absolutely. Yes, that's something we talk a lot about. Okay, so I will say it really is individually based. Okay, if someone's coming in, with just a chronic history of shin splints or plantar fasciitis, and they're one of that, like the guy in the picture with the overpronation, we may try to be more aggressive about getting more of a stability or motion control type shoe. Me personally, I have switched a little bit over the course of my 13 years, and I do try, if I think it's possible, to be able to strengthen the person. So instead of using the external support, basically to try to get the patients and clients to strengthen their own muscle. So if we're talking shin splints, a lot of times it's someone who's overly pronating. So we're looking at strengthening the foot intrinsics, hip muscles. Okay, so if there's a way to do it, if the person I think has some potential to be able to it's not the quick fix by any means, but I do believe it's more of the long-term fix. Okay, so if someone is pretty flared up, we absolutely will. That is the person I'll use the orthotics on, or talk more about footwear recommendations. It is interesting. I mean, and this is something that traditionally we've done all the time. We've tried to prescribe shoes based on foot type, whether the person was a pronator or a supinator or a more neutral position of their foot, and the studies don't really back that, and I was shocked as anybody to hear this myself, because as I said, I'm a runner and always had prescribed shoes to patients based on foot type, and not actually showing that we get it right. A lot of what the research is showing is that through through the gait retraining and some of the strengthening and
Right.
it's actually a little more effective. So I do talk
So
about.
your advocacy is around really looking at the mechanics, looking at the strength, getting to the best place you can get to. But then with all of that, there are some accommodations you could make after you've tackled them. Am I hearing that correctly?
And it's
Okay.
very individual. Like I said, I'll be more aggressive with it if someone comes in with they need that quick fix. They've been dealing with plantar fasciitis for 6 months and are done with it. And so so it just depends on the individual. But
Okay.
yep, it is a conversation we have basically with all my runners that I see.
Okay, great. There's a couple of questions. Could you talk a little bit more about the Healthy Running Program and
Absolutely,
how that whole piece works?
Absolutely, yep. So the Healthy Running Program, basically how that started was, most of the runners we see come in through PT referral, the more traditional PT way. But we had some we'd give talks like this, and people would be interested in coming in for a gait analysis, but they didn't really have any reasons to really come to PT. So basically, we put together this program. Dr. Irene Davis was the one who kind of basically certified a few of us throughout the network to be able to do this, and it's a hour and a half gait analysis and a 45-minute follow-up. Okay, and basically, so on an analysis, we'll do one of the first things we do is look at the video analysis and kind of see, all right, what do we need to look at further? Do they have a pelvic drop? So maybe we have to assess strength a little bit more, or is there a lack of arm swing or trunk rotation on one side, and we get to look at mobility. So basically, we put you through the video analysis. We'll do a postural assessment, strength and range of motion assessment. We'll look at doing some functional tests. Oftentimes it's a single leg squat. We'll give you some gait training recommendations, and then we'll give you some exercises to do. Then usually the follow-up on that is, at least a couple weeks out, because we want to give you time to work on that. Okay. So at least 2 weeks, oftentimes 3 or 4 weeks later, we'll bring them back into the clinic and see, how the exercises are going and how, if they were able to make any changes, so that follow-up can have more of a focus on the exercises. It can have more of a focus on the gait. It's a self-pay program, so I'm kind of flexible in terms of what the clients want to do with that one. If they want to, be more, focused on the video analysis and changing their running pattern, then we'll do that. But if we can help them out more through exercise, then that's the case. I will say it's the way to go if you're a healthy runner, but it's only 2 sessions. So if there's any type of injury that obviously it'll probably take more than 2 sessions to go, getting a PT referral would be the way to go.
Okay, great. And Jorge has a question for you, asking how high should I go in a single leg calf raise when doing the 30 reps that you mentioned?
Great question, Jorge. So what you would do, the way we measure in the clinic, is we see how high you can get off of both feet. Okay, so bilateral heel raise, coming up as high as you can, on both feet. And then, so it's tricky to do yourself because you gotta somehow be able to mark on the wall or how high you got. And then on the single leg, you got to get to that same point. All right, it is not easy at all. Okay, so we're doing a lot of calf strengthening, before we're transitioning, anybody to a 4-foot strike pattern, just because we don't want to cause another injury by by changing a gait pattern and fixing another, right? So we want to make sure you're ready to do that. But basically you want to get to the same height on a single leg as what you're getting to on the double. All right, it's
great.
We go by.
Fantastic. So as we're coming to a close and we're summarizing a couple of different avenues. The first would be if you have an injury, working with your doc or one of our PM&R docs to get a referral and to be able to, go through. So, although we're talking about the video analysis, so talking about treatment, right? So there is the path where you're coming in with maybe an injury versus coming in healthy. So maybe just a little reminder for folks how to engage, what the program kind of plays out like, what the timing is. I think it would be a great wrap up for this evening.
Yeah, absolutely. And I was just going through the chat questions as you were saying that too, Joe. It's, how do we get the gait analysis? Does it have to be through the doctor for PT? If you want insurance to cover it, and it is injury based, that's, so what Joe was saying in terms of time frame, if there's any sort of injury there, the script's got to come from a doctor. Could, if you want it covered through insurance, basically, there's always a self-pay option, but we try to get things covered through insurance for the injured runner. Okay, so yeah, if you can get a referral from a doctor, it could be anybody. It doesn't have to be an orthopedic, but that oftentimes is who we see. It could be your primary doc. Okay, we get you in to PT, and a lot of times if someone's hurt, we'll address the injury component, the injury side of things. Okay, if the injury is not bad and the person's still running, we'll be more likely to do the video analysis right away. If they have some raging posterior tendinopathies, shin splints, or knee pain, we're gonna hold off on doing the gait analysis right away. But it was something we will do. Okay. And then the healthy runner option is just the you do not need a script for that because that's a self-pay program. And we just, in terms of time frame for that, we're just looking at schedule and looking to see if we can book out that 90-minute slot to get you in.
Okay, great. And again, your clinic is located at the hospital, which is right in Sandwich. Yep. And so your patient unit is right at the hospital, plenty of parking, easy to get to. If folks have questions or want to call for more information, they can certainly call the number listed right on the website. So spaldingrehab.org has all of our locations and all of the information.
I'm going to put my email here, Joe, as well.
All right, perfect.
So if anybody needs to, if anybody thinks of questions after this and needs to reach out, feel free. I'll also give you my work phone number here.
Fantastic. And I'll also tell folks you would have gotten your confirmation through our email address for events. You can certainly reply to that as well, and I'll be happy to forward anything to Patrick. As we're finishing up this evening, we're just about at time. Are there any additional questions? I see Patrick has dropped his contact information into the chat box, so we can certainly
One other thing I want to mention, Joe, is just so I do those running analysis in Sandwich. I'm not sure where everyone's from, but there's a girl, Christy Pavlou, that's doing them out of Orleans, and then you got a few up in the Boston area as well. I could, if anybody sent me an email, I could send you out the flyer of where all those are. Most locally you got myself in Sandwich, and then Christy Pavlou in Orleans, but I certainly can get you guys the information for who's doing them more around the Boston area, and you certainly have the option of going to Cambridge too, with Irene Davis.
To Dr. Davis's program. Wonderful. All right, well, I see no more questions, and we are at time, so I want to thank everyone for joining us this evening. Thank you, Pat, for presenting your information, for answering questions. And just a reminder to everyone, this is the first of a three-part series. Next week, we'll be joined by PT and DPT Keelan Godsey, and from our physical medicine and rehab team, Dr. Scott Abramson.
You can't give me
so
a prescription.
We will be meeting again next week at 7 p.m. And then the following week, we have Danielle Nardi, PT DPT, joining us for a session with regard to yoga and running. So we thank you again for joining us, and there's more information available at our website where you registered for this event. Thanks so much. Have a great evening, everyone.